Because nowadays we understand that inflammation, these phenotypes, endotypes specifically, and I will come to that, are extremely important to figure out the prognosis of the disease, the probable course of the disease, and it had an enormous influence on how you do what in terms of surgery. Needs to be adapted to the endotype and phenotype, of course, but also endotype. And of course, we have to, the better we understand pathophysiology, the better we can treat this disease also long term. And you see that very well with all the monoclonal antibodies. Who of you has already used monoclonal antibodies for CRS with nasal polyps? You see? I don't know, it's half, but about half of them. So that is a revolution in our field. It wasn't there when we started with this course. Oh my God, I could show some slides about eosinophils and a little bit of that. And I will still show some slides about eosinophils. But that's not the only thing. We understand much, much better now. And we are just in the beginning of understanding this inflammatory disease, because just to keep you stimulated, what is the regulation of this inflammation? That's the next decade's research. How is it possible that this chronic inflammation is chronic? Normally that's not allowed. It should be stopped. So something is going wrong on a higher level, which we need to figure out. That will make some of you a little bit workless, I'm afraid. But we are not there yet, so please keep doing what you did and learn. But there is, in the future, certainly more to come, and it's incredibly fast now. You know how fast companies go through molecule one after the one. Next one, they have artificial intelligence, they have all sorts of things to increase the speed of this. Well, it started completely different. And that's, I don't know whether you remember Malte Wiegand and Werner Hosemann. I just wanted to show one word here, isthmus surgery. So there is a narrow space, and the surgery was targeting at getting rid of this narrow space. Behind this narrow space there was inflammation. And then there was this discussion with Stamberger, and we had a lot of fights. Manuel, you know that. We have, it was like drama on the stage. Two sides, the one Stamberger school or Messerklinger school, and the other one was then Stannard and so on. But that was also more or less mentioning stenotic areas as one of the things. Nowadays, yes, that is still there, but it's not an explanation for nasal polyp disease. Certainly not, for example. And for most CRS without nasal polyps, it's also not the best explanation. So we have to look into something else, because obviously these are figures we published in 2014 about 12 years follow-up study after endoscopic sinus surgery. There was a recurrence. You have to know what I mean with recurrence. When one polyp comes back in this patient, it was counted as a recurrence. Not necessarily big disease again, surgery necessary, but recurrence. And you see here that the recurrence rate over, 12 years was nearly 80%. With other words, there is a big drive in the mucosa to maintain this inflammation, which we do not understand. We don't know why it is persistent. We all know acute rhinosinusitis. It's over after 10 days. But this one is keeping on, and we do not understand the mechanism. So, but very clearly it came from this bony framework. It comes from this idea of bony framework and isthmus to something which we now call the mucosal concept. It's about the mucosa. It's about the inflammation in the mucosa that makes things understandable. And this was a review on mutation from nature. So that tells you that we somehow changed something important, otherwise I wouldn't have been invited there. So what is the thing behind? When we look today at nasal polyp disease, who of you would say, oh, this is type 2 inflammation? Again, the question again. We look at nasal polyp disease. Who of you would say this is type 2 inflammation? Oh, my God, we have to do a lot of work. Only 3. It is 85% is type 2, but what this slide shows you, that even if you go to chronic rhinosinusitis without nasal polyps, half of that is type 2. Less severe, but half of that is also type 2. And in the former decades, we always think, oh yeah, nasal polyps, more type 2, 85%, eosinophils, just eosinophils. And nobody looked at CRS without nasal polyps, but was assumed it was a type 1 or type something else disease, or 17 maybe. But that's not the case. Here we show that half of these patients with CRS without nasal polyps, according to the definitions you certainly have heard of, are actually type 2. They show eosinophils in the second row, and you see here CRS with nasal polyps. Of course, you see the tissue is different, the remodeling is different, but eosinophils also in CRS without nasal polyps. And there are mixed types where we have neutrophils and eosinophils. In other words, what I want to tell you is that it's not nasal polyps is type 2 eosinophilic and the others are not. It's much more complex. And certainly, the neutrophils also play a role, which we do not understand completely, but we ask ourselves, okay, you treat with an anti-IL-5, your eosinophils disappear in the peripheral blood, they cannot migrate anymore there, and still the disease is not over. So also other cells, neutrophils, and probably many more cells do play a role here. This is looking at markers of type 2 inflammation in chronic rhinosinusitis without nasal polyps. And what you clearly see in those patients, also for non-polyp patients.
Pointer, please.
Do we have one? The finger points in that direction. Not long enough. Thanks. Thanks a lot. Yeah. Okay. So you see here ECP, eosinophilic. Good. 1. If I say ECP next time, you say, oh, eosinophilic cationic protein, because that is a marker for eosinophilic inflammation. You can measure it in the tissue very nicely, and you can say something about the eosinophilic degree of eosinophilic inflammation. Interleukin 5 is the protein or the molecule that makes eosinophils survive, migrate, activate them. If you look at IgE, also a marker of type 2. You know that from allergy. Allergy is a type 2 inflammation also. Is allergy linked to nasal polyposis? Not really. Why is allergy remaining relatively mild? If you look at the mediators in an allergic rhinitis mucosa, it's quite mild. It stays mild, even in the high season, versus the inflammation we see here is about 10, 15 times higher in terms of values of inflammatory mediators. So we do understand type 2, but we do not understand the regulation of it. That's what I want to tell you. So the future is certainly going into the regulation of this disease, and that's extremely interesting. We have studied IgE. Of course, you have this enormous elevation in the tissue of these patients with type 2 disease. There's also staphylococcal enterotoxin antigen. Staphylococcus is one of the possibles, not the only one, but it's a strong stimulus for type 2 inflammation to be developed. You also have IL-17, and you see the IL-17 is a bit higher in the non-type 2. Looks for you the same, looks up on the CT scan exactly the same, but this is a totally different disease from that one. in terms of prognosis and also, of course, in terms of treatments you could use. And unfortunately, if you look at the blood eosinophils, you can, if you have a big group, you can see the difference also in CRS without nasal polyps in the peripheral blood. But of course, there's so much overlap that you cannot use it as a diagnostic tool. But CRS without nasal polyps, type 2, has significantly more asthma and significantly more recurrence. So the same principles as for nasal polyps also apply to CRS without nasal polyps. And of course, there is this second thing, which is called remodeling. So remodeling means this tissue that we see here is remodeled. It is swollen. It is fibrotic partly. There's a lot of edema in it. This is called remodeling. And it is linked to inflammation, but not directly. You can have more inflammation with little remodeling and the other way around. What I want to show you here is just that the remodeling of CRS with nasal polyps and without nasal polyps is completely different. Whereas in nasal polyps, you have especially edema. Your cells are distributed over the large area. The cell-to-cell distance is much larger. In the CRS without nasal polyps, you have a lot of collagen deposition, probably as a sign of upregulation of TGF-beta, which partially also comes from eosinophilic cells. So in other words, the inflammation is similar. Whether you look at asthma, atopic dermatitis, it's the same cells, but the remodeling is different, and another thing where young researchers have to do much more work. So in 2000, exactly 2000, there was a publication saying that polyps are eosinophilic and corticosteroids are the only drug to treat them. This has been changed. First, the first part is not right. They're not all eosinophilic. And second, corticosteroids are not the only drug anymore to treat them. But what you see here very nicely is these very clear eosinophils. You can stain them very nicely. And they are mostly subepithelially, but also distributed through the tissue. What drives them? And in, when was that? 97, we published on interleukin 5. And that is today translated into a treatment for nasal polyps, anti-interleukin 5, to get rid of the eosinophils. And you see interleukin 5 synthesis is upregulated in human nasal polyp tissue. That was the message at that point. At the same year, we had a cooperation with a very nice Swiss scientist. He was a basic scientist, and he was interested in apoptosis of cells, dying cells. Of course, if you have inflammation, how do you reduce this inflammation? By letting them die. And you have here the eosinophils, and by giving anti-IL-5 or taking away the IL-5, you have these eosinophils die within 24 hours. So they're very dependent on the interleukin 5 to give them a signal to survive, to migrate from the peripheral blood into the tissue, and so on and so on. Well, the problem is that so important? Are the eosinophils so important? Who thinks that eosinophils are important in nasal polyps? Okay, 50-50. You think also. Very good. Are they important? Well,
I don't think.
You don't think. You know. Okay, you know. Okay. There are, depending on where in the world you are, more or less eosinophils in nasal polyps. In China, much less. 50% of the nasal polyp patients are eosinophilic, and the eosinophilia is a fraction of what we have here. The polyps look the same. Is it important? Maybe, maybe not. Anyway, we have seen that they are accumulating subepithelially. that where they accumulate, there is sort of loss of epithelium, and this is what I call a eosinophil cemetery, because you have thousands of eosinophils in this area. The epithelium disappeared completely, and the nasal polyp is just a last place for thousands of eosinophils. These eosinophils are not there for nothing. What do we know eosinophils for? When are they good? When are they needed, eosinophils? For a good allergic reaction. To defend us against parasites. That's their original task. And they do that. And in that case, this is Staphylococcus aureus. They misunderstand Staphylococcus. Maybe they don't misunderstand, they just take it as a parasite. And what you see here is these eosinophils are around here. These eosinophils are around the parasites, the Staphylococcus. And what you see in red is the release of major basic protein. They spit on the Staphylococcus and try that way to kill them. And you see here, this is an eosinophil, and woof, he spits these major basic protein, sarcoidin crystal substance, more or less, on the eosinophils. So there is a job they have to do. They are not just there for nothing. Unfortunately, they, even if they disappear, they leave something behind. And that is what we call sarcoidin crystals. We know that from asthma, has been described a long time ago. And here's the proof that these sarcoidin crystals also are available or are made in nasal polyp disease. Now, what's the problem with that? This one, you see, these are really crystals. They form like like little needles or knife-like structures, and they stay there even if you treat these patients with an anti-IL-5 months later. These crystals are still there. So what you see is one of the mechanisms of chronicity. There is a continuous stimulation by these sarcoidin crystals, because there's a lot of neutrophils also coming in because of these, and that is based on, or let's say that is part of the accumulation of eosinophilic products. We call them sarcoidin crystals. Is there anything specific we can do about that? Not really. There has been some research on antibodies against sarcoidin crystals. Research is going on here in Belgium, actually not too far away here, but hasn't led to any studies in humans yet. Now, for those who are not confused yet, I have prepared this slide because we all think, okay, this is T cells, right? The real principle, the real bad guys are the T cells, because they release IL-4, 5, 13, right? 4, 5, 13. 4, 5 is doing the B cell activation, IgE production. 4 and 13 and 5 is the eosinophil guy. Okay. But there is not one T cell. And there's not also a deviation of only CD4 T cells. These are these guys. But there are a lot of CD8 cytotoxic T cells in nasal polyps. And what you see here is that you can even estimate or differentiate them further into effector, memory cells, and so on. I don't want to stress you with that, but you see that there is a complex inflammatory change. And what I like to say at that moment is, if you think about nasal polyps as just normal nasal mucosa with some eosinophils, you're totally wrong. There's not one cell as it was before. This inflammation is going from the epithelium to the endothelium. We have seen that the vasculature loses parasites that normally make the vasculature tight. That's why there is edema, because there's a loss of some cells and a gain of other cells. And you see that here, normal mucosa has not many of these T cells, certainly not the T suppressor cells, the CD8 cells, this is CD4, but the nasal polyp has a lot of T cells of both sides. Everything is enlarged. And I just want to get an idea in you saying, well, everything there is different from what it is before. Allergic fungal rhinosinusitis, I don't know why the next slide is not showing up, but maybe is again a type 2 immune disease. What is it causing? Fungus. That's why we call it allergic fungal rhinosinusitis. A type 2 disease, but the reason for that is more obvious to us because mostly it's aspergillus. So what do we know? What do we learn from that? And I don't want to have anything in competing with Philip's talk about biologics, but I just want to talk to you in sort of principles. What have we learned? Well, how important are eosinophils in this disease? Because for the first time, we can push them out and see what's over. How much result does that have? What about IgE? How relevant is the IgE in nasal polyps? We have measured IgE and they are rocket high. Is that relevant? Does that contribute to the disease? And finally, also other cells like interleukin 4 receptor, alpha, Al5 receptor. We can now test each of these different steps and understand whether there's a role, an important role. Is it a role that can be therapeutically engaged to actually treat these patients? How am I doing in time? So I'll speed a little bit up. You will hear about mepolizumab. Mepolizumab is an anti-IL-5 antibody. I don't go into the study concept. I just show you what happens if you treat these polyps with anti-IL-5. You see, some patients are not doing so perfectly well. They actually don't get better or the polyps grow. And others are doing much better. And some people even have a big success with anti-IL-5. So how can we predict that? That's the real question. In all of these polyps, we see eosinophils. And in some, they're more important than in others. And that makes it, of course, very difficult. I just wanted to go. So what you see here, if we could predict those super responders on an anti-IL-5, that would be perfect. That would make this medication really worth the money. And you see here also there's a bigger proportion of patients than in the control group answering to this, but it's not 100%, it's not even 80%, it's less than 50% who are really answering very well to this medication. And if you have an expensive medication with a responder rate around the 50%, that's like throwing coins. And you cannot predict it. And that's one of the difficulties we have with biologics. What about IgE? If you hear about allergy, you know IgE is involved. Yes, of course, very important. You measure it, you do skin prick testing, you measure it in the blood. In the tissue, these patients with nasal polyps have IgE values in the several thousands. You can or you cannot see that in the peripheral blood. It's not necessary that the IgE in the peripheral blood is increased. And your skin prick test is unrelated to whether they have nasal polyps or not. So, what does it say? This slide here, you have this high total IgE, and if you look for the different specific IgEs, you find hundreds. So it's a polyclonal IgE formation. It's not specific to house dust mite or grass pollen. It's all over the place. Is it functional? We guess yes. I think we have shown that. But it's not as functional as it is in an allergy, for example. So IgE we know it as mast cell activator, so to speak, has also other functions, and I will not go too much into details, but they also are exposed on B cells. They talk via the CD23, the low affinity IgE receptor, to other immune cells. So it's not just IgE to degranulate mast cells. And there's one guy which we very often find in CRS with nasal polyps, and that's Staphylococcus. 80% of our polyps are somehow colonized with Staphylococcus. And we show here that the role of Staphylococcus really might be not just that it's intramucosally and intracellular even, but it's linked to the Staphylococcus aureus IgE formation in these patients, and it's linked to the total IgE. So Staphylococcus is, at least from that aspect, one of the possible drivers, and we didn't find that for pneumococcus or whatever. Staphylococcus is quite exceptional in driving type 2 immune disease. Okay, now we treat that, anti-IgE, and we have a -1 change. The patient started with a score of nasal polyp 6, let's say, and there's a -1 with an IgE antibody. Are we happy with that? Well, in some patients it works better and so on. Again, if we could predict in what patient, it would be fantastic. If we do it long term, and this is over 1 year, 52 weeks here, then you see that stays at that level. It's not a question of doing it continuously and getting a better answer. Within the first, let's say, 12 weeks, you know already approximately what will be your result to this, your response to this monoclonal antibody. And finally, we heard that type 2 is much more complex. It's not just eosinophils and IgE. It's involving, ILCs, innate lymphocytes. It's involving T cells, and of course, then you have the B cell here, which is driven making the IgE. But it's a quite complex inflammatory disease. There are more than 3,500 different molecules involved in regulating that. And we target one and hope that the whole thing disappears. Of course, there is much more to do. And if you look at that slide, then you see that there are so many cells involved. Endothelial cells, as I said before. Look at endothelial cells in a normal, where is that one? That is nasal polyps. Yes, this is, yeah. So here you see the endothelial cells here, right? This population. Normal nasal mucosa, a lot of endothelial cells. In nasal polyps, these endothelial cells nearly disappear. That's why there is edema, why there is leakage, right? On the other side, this is normal healthy mucosa. There are T cells, but not many. But these are totally overweight in nasal polyps. So a lot of T cell activity, cytokine production in these. And here also fibroblasts. This is normal nasal mucosa. This is the polyp. The fibroblast population gets lost. So you don't have the tissue link, the tissue structure as you had before. And then you understand more and more this complex disease.
Klaus, can I ask you just on that last slide, as a proportion compared to normal control, which cell population was more represented? Was it B or plasma cells even?
Was more representative.
How many magnitude over baseline, over control tissue?
This here is a magnitude.
T cells?
I think T cells certainly would be my favor here. I didn't look at each of these groups separately, but that one is certainly 20, 30 times the number of those cells.
Isn't it amazing? B cells are almost the same.
B cells are also amazing, yes. The B cells here, you see part here, and much more here. But I mean, again, what I want to show you, every cell population is involved in this disease. Some increase, some decrease. It's a very complex picture, but it helps us to understand what might be the answer for those patients in terms of treatment. Just to close here, of course, then we say, well, it's type 2. Type 2 is orchestrated via IL-4, IL-13. Both of these bind to the IL-4 receptor alpha. What about we deal with this anti-IL-4 principle? And this is what we call the Liberty studies or dupilumab studies. And you remember mepolizumab was minus 0.7 nasal polyp score after 24 weeks. Omalizumab was minus 1. And now we have a minus 2. Wow. That principle, obviously, in these studies, and head-to-head studies are already planned, partially started already. You see very clearly that this principle has a bigger range in these phase 3 studies. Much more to be done. Registries are now built in Europe to figure out what cells in really, what biologics in real life would help most of the people fastest, long sustained results, and so on. And here you can see that in that little bit extreme patient, a good responder, that this really makes polyps nearly disappear. Don't panic. This is only 15% of the population treated with dupilumab. But there is effect, no doubt. The others do a little bit less, but the average is minus 2.4 nasal polyp score in these patients.
Wait, can you go back? Can you go back? Well, that patient had surgery initially.
Yes, of course. It was a typical patient with 3. I mean, if you look at the studies, these patients have been 3 times operated before they are on the biologic. Most of them, not everybody, but most of them.
That's the indication.
Yeah.
So far, that's the indication.
No.
Have previously.
In my eyes, it's not.
No, but in the official protocol.
Yes.
Or recommendations.
It depends a bit on the nation, I understand. It's a little bit different from country to country, but you have to be very sure that you stay within the indications for those biologics. And that might be that there was a kind of surgery before. However, how is surgery defined? Yeah. Is a Blakesley in the ethmoid already surgery? Of course. Then I have a easy game to say, yes, today I do surgery, next week I start the biologics.
Depends on how much you can build.
Exactly, you know it. Well, anyway, if you look at smell, what happened to these patients when we did their study was that they spontaneously called us and told us that they could smell again. And that's an enormous result. And this is the UPSID score, which measures that very steep onset. We didn't understand it because the polyps were still there. But the smell was one of the first signs that really reacted enormously. So what do we learn? Smell seems to be different from nasal polyp growth, and IL-4 and 13 are probably the mediators or the targets for smell, loss of sense of smell. So that's what you should treat to get smell back. Now what we end up is a very complex picture. You have heard about IL-4, IL-13, IL-5, and I just gave that lecture to tell you that this is proof of concept, that this is not just someone measured IL-5 and reported about it, but it is translating into treatment. And of course, this one. What I wanted to show you is a little bit of the future. There's something that comes directly from the epithelium, IL-33, 25, TSLP, and these ones, which we do not understand yet so well, activate the innate lymphocytes. Is there a possibility to also, work on these mediators? Maybe even more effective or maybe less effective, we don't know. But these studies are also running. And I think this picture seems complex, but in 10 years it will be very simple versus what you will have then. explaining you really the pathophysiology. What is the role of each of these cells? What is the role of each of these mediators? For us, this translates into disease. So if you have type 2 disease, you have more asthma. Very clear. So disease severity, recurrence, and disease comorbidity clearly are linked to the type of inflammation. Just shortly, uncontrolled severe nasal polyposis is something we created as a term where you can say, well, I have done a lot because it's uncontrolled. I did surgery. I had oral steroid treatment, which we know is very temporary, and the patient still suffers from this disease. And in that case, it's an uncontrolled severe chronic rhinosinusitis with a polyp score of more than 4, and we need to do something else. And that might be a biologic, as I just mentioned, and we have different targets, and we will hear more about the biologics. How do I define type 2 in this population? Because that's important for you. You don't want to give an anti-IL-4 receptor alpha antagonist to someone who doesn't suffer from type 2 immune disease. And it's actually not so difficult. The first question is very simple. Has this patient asthma, yes or no? Can be mild asthma, but asthma. If that question is yes, you are 94% knowing that this is type 2. Asthma is a very good type 2 marker. And the next question is, you look at blood eosinophils, not because blood eosinophils are so important, but just as a marker, as a simple marker for daily clinic. If the blood eos are more than 300 at one time point over the last year or two, then you'll be 95% or even 98% sure that this is type 2. So a simple algorithm that supports you when afterwards the insurance company says that, oh, you are prescribing so much type 2. We have that in Germany, for example. Can you give us a hint how you select these patients? And so this is the model. Comorbid asthma, blood eosinophils as simple markers. Of course, if you had a former biopsy with eosinophils, just described by the pathologist, you also know it's type 2. And what you should learn, once type 2, always type 2. They don't change. They just go through the life as type 2 inflammation. So to stop here, to differentiate type 2 or non-type 2 disease is very important for the whole concept of treating these patients, of telling them what will happen in the future. Is there a possibility to treat specifically type 2, and how do I get into biologics, and how do they, and that's one question we certainly discuss later, how do I differentiate to start with a surgery or start with a biologic? Who is to start with the biologic? Who starts with the surgery? Who starts with nothing, the rest? Okay, once more. Who starts with a biologic? You have choice. Either biologic first, not that you stay with that treatment, but if you have a patient with severe, chronic, uncontrolled disease.
That's the clarifier.
Yeah, but
Option three is a nasal
which is?
steroid spray.
No.
Actually, what
Of course, they are all on topical steroids. They came in with double dosage steroids for 5 years and still have polyps, okay? This population, in that case, you would say, well, I need to do something more. And maybe I start with a biologic, but do you think the biologic will solve it? I told you 15% of them have a score of 0 or 1. The others, you have to do maybe something else. So if you have that patient in front of you and you plan for the next 10 years, not for the next 10 days, but 10 years, the first thing you do is try a biologic. Because after surgery, for a while, you cannot. right? Because if you remove the polyps, how do you read whether that works or not? And I showed you that depending on the monoclonal antibodies, you have between 50 and 85% responders. It's not everybody. So please first consider, is that type 2? What arguments do I have for type 2? If so, first, and you want a long-term treatment, look at the biologic, then treat with surgery, and then see, of course, continue with the biologic. That's the idea, to prevent recurrence of disease. And that was about
disease pathophysiology by Klaus for what we call bilateral diffuse CRS with type 2, non-type 2 disease. We will try to incorporate this also in the type of surgery you should perform for these types of disease. And I will show you what is, in my opinion, the workhorse for every endoscopic sinus surgeon is doing a very complete ethmoidectomy. So it means that you want to create a single sinus cavity where you have access to the maxillary, the ethmoid, the frontal, and if needed, to the sphenoid sinus. So this morning we discussed everything which was unilateral, isolated sinus disease, especially around the maxillary. It's clear that this is another type of disease. So this is really diffuse inflammatory disease, and only working at the ostia will not solve the problem. So it means we have to master the anatomy of the ethmoid sinus, and it's one of the most complex structures we have in the nose, because it's quite a labyrinth and it has a high variability, but there are some certain landmarks which are quite constant that you can recognize in most of the patients. So we make a division between the anterior and the posterior ethmoid cells. So the anterior ethmoid cells are the cells that are anterior to the basal lamella, and the basal lamella is the attachment of the middle turbinate to the lateral nasal wall and also to the lamina papyracea. And in this anterior ethmoid, you will have a bulla ethmoidalis. You already opened, most of you already opened the bulla this morning. You have the Agarnasi cell, which is the most anterior ethmoidal cell you have. You have some cells that lie against the medial orbital wall, and then most of the times, not always, just behind the bulla ethmoidalis, you can have a recess. So in the space between the posterior wall of the bulla and the basal lamella. Now, if we go to the posterior ethmoid, then we have to pass through, if you want to work in an anterior to posterior direction, we have to pass through the basal lamella. So everything which is behind the basal lamella of the middle turbinate is considered as posterior ethmoid cell. Compared to the anterior ethmoid cell, where you have multiple and smaller cells, you will have larger and sometimes a single big ethmoid cell in the posterior ethmoid. So the more you go posteriorly, you will see that the cells become bigger. So the border of the posterior ethmoid laterally is the orbit. You have the lamina papyracea and the orbital apex. You have the superior skull base, and medially it's bordered by the superior turbinate, which is a very important landmark to see the depth in which you are working, if you're in the posterior ethmoid or not. You also see that the posterior ethmoid tends to be a little bit more widened than the anterior ethmoid. So the anterior ethmoid is narrower, if you look on it from anterior to posterior, than the posterior ethmoid. Of course, you also have to have a coronal view. So I cannot stress the fact that you have to learn to read CT scans, and you have to have a checklist. Really, in the beginning of your career, you have to have a checklist in mind to every check the single, let's say, structure you need to know when you do surgery. And one of those good checklists is the closed checklist, where you look at the cribriform plate, the lamina papyracea, Onodi cells, the carotid, and the sphenoid sinus. So if you're in the ethmoid cell, you have to be concerned about the slope of the skull base. So if you're in the anterior ethmoid cell, you will have sometimes a quite oblique skull base. The more you go posteriorly, the more horizontal your skull base will be. And you have this lateral lamella, which is a continuation with the middle turbinate, where you are at the olfactory cleft, which is a very vulnerable region to have a CSF leak. and we will come back later on the depth of this leak, of this clefts for CSF leak. Now the structure, which is sometimes quite complex to understand, is the basal lamella. But in essence, it has a vertical part and a horizontal part. If you look on it from anteriorly, you will see that this is the horizontal part. From the side, it is this part, so it goes away from you. So it's the, let's say, the lateral attachment of the middle turbinate, and anteriorly it goes upwards. So this is the middle part, which is really going upwards to the skull base and to the orbit. Another important landmark is the anterior ethmoidal artery. When you will do a ethmoidectomy, it's a structure that you always have to identify on each CT scan you see, and you can identify it on every CT scan. In this case, when you have a big supraorbital cell, it's very easy because you always see these bony prominence, and you will have a canal which runs from laterally to medially to the area of the olfactory cleft. But sometimes when you don't have a supraorbital cell, you will see that it's more here in the bony canal of the skull base, and then you have to judge it that it's the first slice after, a coronal slice after the globe of the eye, or when you see the articulation between the superior oblique muscle and the rectus superior. There in between, you will have the anterior ethmoidal artery coming out. From a surgical perspective, when you do an ethmoidectomy, you will see that this anterior ethmoidal artery, so now we are looking from medially to laterally inside the ethmoid. So this is the area of the bulla, this is the level of the basal lamella, and this is the frontal sinus with the nasal frontal outflow tract. So your anterior wall of the bulla or a suprabullar cell will always protect your ethmoidal artery. So the anterior ethmoidal artery will always be in between the lamella of the basal lamella and the anterior face of the bulla. So that's a way to, let's say, identify during surgery where your ethmoidal artery will be. Then when you do a complete anterior ethmoidectomy, so it means that you will also have to remove all the anterior ethmoidal cells, including the agar nasi. So it means that you will also work in the nasal frontal outflow tract. And we were all learned by this Kuhn classification with Kuhn type 1, type 3, type 4, but you have to adopt a new classification on frontal sinus anatomy, which is very simple. So you have here this asterisk. This is the agar nasi cell. It's the first anterior cell that you see on the coronal image. This is a sagittal image. If you have a cell above, which is not in the frontal outflow tract, so below the frontal beak, it's called the supra-agar cell. And if this cell will go into the frontal sinus, it's a supra-agar frontal cell. So this is really something you have to look for on each CT scan. And the same is true for the bulla. So you will have a bullar cell. You can have a suprabullar cell. And once the suprabullar cell is going into the frontal outflow tract, you have a suprabullar frontal cell. And this is really pushing your nasal frontal outflow tract, or anteriorly if you have very big suprabullar frontal cells, or posteriorly if you have very big supra-agar frontal cells. So really look at the anatomy of the nasal frontal outflow tract. Now you have several models of frontal sinus anatomy with blocks and with drawings, but I like to keep it simple, and I learned a technique that helped me a lot by Aldo Stam, which is the vertical bar technique. And it's something you have to try to look for today, this afternoon, to look whether you can find this vertical bar. So exactly what is this vertical bar? So we are here looking at the middle turbinate. Number 2 is the uncinate process. If you remove the uncinate process, you will always have a remnant superiorly in the medial plane, and you will have your agar nasi cell over here. So you're really looking from below into a small egg or eggshell. If you have this vertical bar, then in most cases, your drainage pathway of the frontal will be behind or medial to it. So if you take this very tiny cotonoid, so if you have these cotonoids, you put it in 1 in 2000 adrenaline, and you just push it very gently upward, you will do a frontal sinus dilatation with a cottonoid and just push this cell medially. And if you have only an agar cell, you will already arrive in the frontal. If you have a supra-agar cell, you will have to do it twice. So you really follow the frontal drainage pathway. And by using this, you keep the bulla intact, so you are away from the danger zones, which are the skull base and the anterior ethmoidal artery, and you have identified the frontal already in the beginning of the surgery. And in fact, this vertical bar technique is just the same like uncapping the egg, as was told by Heinz Stamberger. So, but it simplifies your approach to the frontal and leaves your bulla intact. And in my opinion, I like the bulla intact technique because it gives you a completeness of the surgery in this area. What we actually quite often see is that surgeons start to open the bulla, then go to the posterior ethmoid, then try to go back, but then here they got a little bit confused and they leave cells over there. So if you do the bulla intact technique, you are already addressed the pathology here, and then you go backwards. You protect the skull base, you protect the anterior ethmoidal artery, and you work especially in the natural drainage pathways of the frontal sinus. So what are the steps to do a complete ethmoidectomy? Well, you have to have a certain logical order in the steps. So first of all, you have done your middle maitland trostomy, so with your uncinectomy. Then you go for the bulla intact technique and start with the draft type 2A. You open the bulla, you perforate the basal lamella, then you identify the posterior ethmoid, the skull base, which is the most easy location to identify except from the sphenoid sinus, and then you go back anteriorly. That's in a sagittal plane. So you go from, you stay quite below, you go posteriorly, you identify the skull base, and then you come back anteriorly. So this means that you have to pass through all these lamella. And I really like the concept from Ansel Sama, who said that you have to pass through several doors. And these doors bring you to another room, and these doors are made by lamellas. So this is the lamella technique. So you have here the first lamella is your uncinate process. The second lamella is your bulla. The third lamella is your basal lamella. The fourth is the superior turbinate, and the fifth is the sphenoid phase. So if you leave small remnants during this progression, you will count the lamellas and you will see how deep you are. But also in the coronal plane, there are some important landmarks, and it was already stressed this morning. I think the most important landmark is the floor of your orbit or the roof of your maxillary sinus. So this will give you a very nice constant view on the level which you are working. And of course, you want to stay away from the orbit and from the skull base. So it's very important to recognize this angle. So the angle between the lamina papyracea and the roof of the maxillary sinus. So if you stay at the level of the roof of the maxillary sinus, to go posteriorly, you are in a safe zone. And especially when you're working medially. So these are some surgical images. So we have removed the uncinate process. We are looking here inside the aganasi. You have here the vertical bar. This is a small cleft which will lead us to the frontal sinus. And this blue structure, this is the bulla. So what you do with your instrument, and you can use a Kuhn ball probe or a frontal sinus curette, is that you try to find this space between the middle turbinate and this vertical bar, and you go from posteriorly to anteriorly and from medial to lateral. And you just flip this aganasi away. Here you see a video of this. So we have the middle turbinate, we have here the agar cell, we have the bulla. So we just go behind it and we just flip it. And if it's difficult, you can push some cottonoids upwards. It will decongest the mucosa and you will have nice access to the nasofrontal duct. So here we remove the bony wall of this aganasi cell, And here in this case, you only had one cell, you only had the agonizing cell, so we are already into the frontal. So it takes very little effort to find the frontal if you leave the bulla intact. And of course, later on in your surgery, you have to complete this draft type 2A because you also want to have the superior attachment removed of the bulla ethmoidalis so that you will have a nice slope from the frontal sinus back wall to the skull base and no partitions over there. Okay, so here we are at the bulla. You can choose whether you go with your curette into the retrobular recess, but what is important is that here you see the level of the roof of the maxillary sinus, that you stay below inferior and medially, and then you're safe. The danger zones are over here where you have probably the lamina paparicia, and you have the skull base and the anterior ethmoidal artery somewhere over there. So you can remove this bulla ethmoidalis as shown this morning by just penetrating it with a curette or going in the retrobular recess and using a debrider or a cutting Blakesley to remove the bony partitions and the mucosa. Okay, the bulla has been removed, so now we clearly see the level of the lamina paparicia. You have the level of the roof of the maxillary sinus, and here we are looking at the basal lamella. This is the inferior level of the horizontal part of the basal lamella, and you have the space between the roof of the maxillary sinus and this horizontal part, and this is the safe zone again to enter into the posterior ethmoid. And once you are in the posterior ethmoid, you will be able to identify the skull base quite easily, and you can progress into the sphenoid sinus if you want, but that we will show in a later module. But here we looked at it on another side. So we have the middle turbinate, and an important structure once you're in the posterior ethmoid is the free edge of the superior turbinate. So if you went through the basal lamella and you remove a little bit of this vertical part of the basal lamella medially, you will be able to see this free edge of the superior turbinate. And that's really a confirmation that you're really inside the posterior ethmoid. And from that route, it's easy to go to the sphenoid sinus, again, transnasally, or you can go transethmoidal to the sphenoid sinus. And then you can make this kind of box where you have here the horizontal attachment of the superior turbinate. You have your superior turbinate over here, the lamina paparicia, the skull base. And if you draw an oblique line from medially to inferiorly laterally, you have a safe zone over here to enter the sphenoid sinus. The reason that this zone is safe is that here you will have the skull base, you will have the optic nerve, and you have the carotid behind. So if you stay medially inferiorly, it's called Bolger's box. That's a safe way to go into the sphenoid sinus. But personally, I prefer to go again here medially to the superior turbinate, and then I identify the natural ostium. And then we come back anteriorly. So we remove all the bony partitions that we still have on the lamina paparicia and on the skull base. We identify your superior ethmoidal artery, anterior ethmoidal artery, which is always oblique. The posterior one is sometimes difficult to see and is running really across your image, while the anterior ethmoidal artery goes from laterally inferiorly to superiorly and medially in your image. Now, how does this relate to surgically for diffuse CRS and especially type 2 disease? We have learned from Klaus that we have certain endotypes and phenotypes, and I think especially the group with polyps and with asthma combination need a different type of surgery than we are used to be. And like Klaus said before, what is surgery? It's a difficult, in my opinion, terminology to have a good definition on the extent of surgery and what type of surgery you should do. But I think we all agree that a polypectomy for an inflammatory disease is just treating the tip of the iceberg and leaving the majority of the pathology behind. So if you look at the natural history of sinus surgery, I think we all were trained with this isthmus surgery. We are now going into real compartment surgery where we want to have a single sinus cavity, and some of them also promote more radical surgery. And if you look I don't think that this is really a staircase we should do for our type 2 disease. I think with the type 2 disease, you're already here at this level of a complete FES. A mini FES or single sinus surgeries, it will not work. You have to do at least a complete sinus surgery where you remove all bony partitions in the ethmoid sinus. And one of the techniques that has been developed by Klaus is the reboot. And the reboot means that you try to remove as much of the inflammatory mucosa as possible, of course, in the ethmoid sinus, in the frontal, and in the maxillary sinus. And that you keep the areas which have normal tissue or normal mucosa, which are the turbinates, middle and inferior turbinates, and if possible, superior turbinates. Of course, it's not always easy to go here and here without doing very aggressive surgery, so it's not tumor surgery where you want to have big access. But at least, in my opinion, what a reboot surgery is, the goals of a reboot surgery is to remove all the polyps, remove all the mucosal inflammation. So we really want to reset the inflammatory memory. We want to create a big cavity which has a good access for topical therapy. And here you see an endoscopic image during surgery and then after 6 months and 1 year. And it really heals very well. So you really get a functional sinus cavity. But of course, these patients continue to wash their nose, to rinse the nose, and use topical steroids. Now, there have been similar techniques described. So we have reboot with mucoplasty, we have nasalisation, which was already described by Jankowski. I think what they all have in common is a complete surgery. And I think that's the most important message for you, is that when you're treating inflammatory disease, you have to do a complete surgery. And this complete surgery will only be effective if you combine it with a good long-term postoperative therapy. And what we like to give to our patients are washings where we add the topical steroids. It could be budesonide or mometazone, because with creating this good surgical state, you will have good access for your topical therapy. So what about the postoperative care? I think you can argue about it for a whole day. You find, in my opinion, very little evidence what to do, and most of the things are, let's say, based on the experience of a center or a single individual. What we like to use is, like I said before, the topical therapy with budesonide lavage, which are continuous treatments, so long-term treatments, and we give the patients for about 3 to 6 weeks also oral doxycycline. We have shown in publications that doxycycline has an effect on remodeling, on wound healing, so it gives a better outcome when you put your patients on doxycycline treatment postoperatively. I think the real debate in the future, yeah? It's 100 milligrams. So you start with 1 day 200, and then you go to 100 milligrams 6 weeks. I think the real debate will be if you could combine that with a biologic postoperatively. So I think there is the interesting field coming up for surgery and biologics to combine them. Because in my opinion, it's not one or the other. So it will be, yeah.
Can I make a comment?
Yep.
Just someone in the audience said immediately, what dose to use.
Yeah.
If I have to have one comment about the approach of creating a neosinus cavity and then treating it topically, it's not people's topical regimes, their dose, all of that makes the difference. It's their sinus cavity they create. They don't completely open the sinus cavity up and remove every partition and create a simple box. It's just not. It's not the dose. It is, unfortunately, the surgeon's skill at creating a cavity that can effectively be treated. It's the biggest elephant in the room.
I totally agree. I think in my opinion, why we could show with reboot that it's superior to, let's say, conventional sinus surgery. Because you, by, let's say, definition, you're more aggressive or more complete. The question is, it's aggressive, it's complete. You're more complete than aggressive.
You have to be. If you want to try to strip a bit of the mucosa, it forces the surgeon to go to the boundary of the cavity. I would say most people don't even get close to the boundary of the cavity. And so hopefully in the lab this afternoon, we can show some simple rules. I think Klaus and I are dissecting, we've got different styles, but I think we end up with the same cavity. Is like how you go about being a surgeon, despite all the polyps, how do you create that cavity?
Okay. So how to prevent complications? I think you can discuss whether it is a complication or not, but I think in terms of long-term control of disease, a lateralization of a middle turbinate can be a complication because it prevents you of getting your washes and your steroids inside the ethmoid sinuses and maxillary sinus. So it happens in about 1 in 4, and the key factors that cause this is that, of course, when you cut through the horizontal portion of the basal lamella, you will destabilize your middle turbinate. That's the first thing. If you work too much in the axilla of the middle turbinate, you can have scarring over there and also lateralization, and also opposing trauma between the head of the middle turbinate and the lateral nasal wall can cause a synechia. So you have several solutions for that. If you're afraid to have a synechia formation, you can use spacers. It can be a Medocel. It can be a drug-eluting stent. It can be whatever, in my opinion. But you can also suture it with a resolvable suture where you go from one middle turbinate through the septum to the other one and return. That's a very effective technique. And also you can cause a synechia over here between middle turbinate and septum. So there are many techniques described. I think none of them is superior to another. But also what is important is to do frequent debridement postoperatively. So the other complication is CSF leak. Of course, when you push to the boundaries, maybe so far we have not shown that, but you could be more prone to complication. But a good understanding of the anatomy and also a good CT scan on beforehand will prevent you of having a CSF leak. It's difficult to see, but this patient had unilateral rhinorrhea on the left side after sinus surgery. And you see, if you would play a little bit with the bone window, you would see that here at the lateral lamella, there was a dehiscence. And of course, bleeding can make it difficult to visualize the anatomy, previous surgery, and of course, failure to appreciate the anatomy. If you have a asymmetry, like you see over here, it's quite horizontal, here it's quite steep, that can be more risky to have a CSF leak. But also, if you look at the level or the ratio between the maxillary sinus and the posterior ethmoid, it will give you a lot of information. So the higher the maxillary sinus compared to your posterior ethmoid, so the ratio, if it's more than 2 to 1, you are at a higher risk of having a CSF leak. Also, on a sagittal image, the more, let's say, steeper the skull base is, you're more prone to have a CSF leak in the middle of the ethmoid cavity. And of course, if you look at those Keros classification, so people with a Keros type 3, so with a lateral lamella of more than 8 to 16 millimeters, are also more prone to have a CSF leak in that area. So again, I want to stress that you have to have thin slice CT scan in all planes. So don't be satisfied with only an actual image. You need a coronal, a sagittal, and an actual CT scan. Then orbital complications, retrobulbar hematoma, I think it will be covered in module 6. But of course, if you are working on the lamina papyracea, and especially in patients which have diffuse polyposis, you can have a demyelinarization of the lamina papyracea, and you can have, if you breach the periorbita, you can have orbital fat exposure. It's not a disaster, but don't try to push it in or don't try to pull it out, just leave it like that. So don't touch it and continue with your surgery around. But of course, ocular muscle injury, that's a more devastating and severe complication. And what you have to keep in mind is that if you look on this image, here it's an image where the fat is black. So anteriorly, your medial rectus muscle is the muscle which is most at risk of having a damage, is surrounded by more fat than posteriorly. So if you're in your posterior ethmoid, your medial rectus muscle will be almost completely against your lamina papyracea. Of course, you have the periorbita in between, but there will be almost no fat between. So the area where the medial rectus muscle is damaged most often is in the posterior ethmoid. It happens when you are not working, let's say, parallel with your instrument to the lamina papyracea, so when you are going towards the lamina papyracea, or when you are really pushing with the debrider inside the lamina papyracea. And then it can go very quick that you have an injury of the medial rectus muscle. And it's a very difficult, let's say, complication to repair. So your patient can only be satisfied that they have no diplopia in a straight gaze, but it will be almost completely impossible to restore a complete ocular movement. So here you see this is the area where most often the medial rectus is damaged, and you see that when looking straight, the eye will turn outside because it's of the traction of the lateral rectus muscle, and also when looking laterally, you will see that the eye will not move. And if you have an orbital complication, so if you see fat, for instance, you have to say to your patient that he cannot blow his nose for at least 3 weeks. Because if the patient will blow his nose, you will have a emphysema in the orbit, which can be quite severe. So how to avoid? Look at the CT scan. Some patients had a trauma before, you don't know, and have a prolapse of orbital content into the ethmoids. Identify the roof of maxillary sinus, so I keep on repeating myself, and the lamina papyracea early in the procedure. Work parallel, not in direct direction, but work parallel to the lamina papyracea. Be careful with debriders in this area, and of course, do not blow the nose. I think to end some general tips, what we saw this morning is really you have to zoom out when you do an ethmoidectomy. Don't go very close with your scope into the ethmoid. You really should stay a little bit outside. You really should see your middle meter antrostomy, the roof of your maxillary sinus, and the level of your lamina papyracea. If you're doing surgery on, let's say, non-type 2 disease, try to be mucosa sparing, but be more aggressive when you have a type 2 disease. And if you're lost in the ethmoid, then you just go to the sphenoid sinus, because there you can identify the skull base, and then you can go back anteriorly. Another way to identify is to look for the free edge of the superior turbinates. So, any questions? Yeah.
Power saving.
Philip is using a Macintosh. We need to give him some more time.
So I will start easy so that we are certain, but Thibaut did that already. What is your age? Just to see.
That was not so indiscreet.
Oh.
Hey, I'm the only one. Klaus, come over. Klaus.
You should vote.
I'm too old. He still has to vote here.
No, it's just to make you in the system, so now we move. This is something, how many sinus surgeries have you done? I will use it in... The code is, for those who lost the code is also up there, so you can still go in. Yeah, the code is still up there, so if you are not in yet, you can 577348550. It's just to get you into the system. Okay, it's already 33 people in. You can still join later if you are. So in Ghent, I think we worked for quite a long time. I'm more than 25 years when I joined Klaus. And I think we were very lucky to fall in a team, not only with ENT surgeons, but also with people at the lung department who are interested in research and in these kind of insights. And what did we learn? Every Tuesday afternoon, I have a joint clinic with the lung physicians. And what we learn is that you would think that severe nasal polyps is severe asthma. But that's not true. You have severe nasal polyps with mild asthma or even no asthma. You have severe asthma with a little bit of polyps. And sometimes you have patients with severe asthma and severe nasal polyps. That led to some frustration because the lung physicians first had biologicals and we didn't. And we always hoped that they would have severe asthma to treat our polyps, but that was not the case. Also, if you look for how they look at it, they look a little bit different at how we should treat disease than how we surgeons do that. And that always gives an interesting view. So the questions that are there is, what is the optimal medical treatment for your patient? not only for the nose, but for the patient. Do we need surgery? Do we need biologicals? What I saw over the years, the first years when I went to the lung department, I went there to catch surgeries, to get surgery on to schedule them. But when they were introducing their biologicals, I learned that actually the polyps might not totally be gone, but that the patient was not interested anymore in a surgery of the nose. So that's a different thing. So I saw the decrease in that population. So I will give you some cases because I think that's what we are here for. We start with a young lady, 22 years. I saw her recently. She has a runny nose, sneezing, postnasal drip, cough, nasal obstruction, headache all year round, no asthma, no dyspnea. She has a house dust mite allergy. She already had a CT scan in 2017 showing a pansinusitis. I think it was maybe also taken in the wrong moment, in an acute phase. You see some bubbles, but it was really full. Every sinus was some problems. She had many courses of antibiotics, sprays. She did everything, and she was referred by the GP saying, maybe you need to do a little bit more, or she was actually sent in for a sinus surgery. But before we do that, so I didn't take a new CT scan, because when I look in the nose, I saw there was purulent secretion, so I saw there was swelling, I saw there was disease. So for me, it was clear based on the symptoms that she still had some problems. So my question is, what is...
Wait, can you explain the abbreviations below? Because I pretty dumb in English abbreviations. HDM, SPT.
Yeah, that's house dust mite allergy. Yeah, skin prick test in blood, and in the skin prick test you...
But before we go on to treatment, we should really, because we've had all this discussion about phenotypes, we should say, what is the primary problem going on in this patient? She is far more likely to have a simple inhalant allergy than she is severe type 2 adult onset nasal polyps and asthma. Almost by definition, she's just someone who's got allergy and has had a viral event, you've captured the viral event. I think we need to start talking in the terms like this, because rather than saying, okay, what are you going to do? Because there's no role for surgery here, in my opinion, initially. What's the underlying problem? Severe allergy, untreated allergy.
Well, yes, I know. That's what at this stage you don't know. Huh? So that's my question. How would you treat this patient now? What are your options? And I have nasal saline, nasal steroids, systemic steroids, amoxiclavinate, clarithromycin, doxycycline, antihistamines, allergen-specific immunotherapy, or biologicals, or something else. And if you mark something else, you have to tell me what is something else.
Can we mark a couple of them?
Of course, yes. That's possible. That's possible. It's just to bring the discussion here, what you will start with, or what's the plan for your patient. And you're right, I think we have to talk about allergy in the patients anyhow.
What is the driving mechanism behind this girl's problem? This is what we need to ask.
Yeah.
Then that directs treatment after that.
Yeah. So what you see here is nasal saline. Well, that's the cornerstone of sinusitis treatment. Nasal steroids is important. Systemic steroids, that is maybe. We are not so convinced of that, but you can sometimes use it to get the patient to phase. Amoxiclavinate I would not use. There is a vast amount of data showing that short-term broad-spectrum antibiotics doesn't work in chronic disease. Clarithromycin, there is evidence that it could work. Doxycycline, I will come back on that, but in chronic sinusitis without nasal polyps, it's not the preferable thing. Antihistamines, well, that's part of the treatment of the allergy, and then of course allergen-specific immunotherapy should be discussed, or I discussed that with this patient, and that's immediately what you pointed out, that this is something to discuss. But sometimes you have patients that are liking to go for surgery and don't like the option of immunotherapy because it's a lot of work. In Belgium, it's not reimbursed, so it's one of the issues. Biologicals, there was 2 people writing down biologicals. It's a type 2 because it's allergic, so but I think there is not so good evidence there. Yes?
Yeah, I was gonna say, this idea that, yeah, I agree with you. I hear this, that patients want an operation. They don't like the idea that it's
No.
an allergy. They just want an operation. And we've got to get over that as a profession. We have to deal with their problem.
Yeah.
The problem is, what do they expect? They expect this one surgery, everything is solved. And if that is something
You have to
So,
let them go down the road and become someone else's
So
operation, you know?
I will tell what we did, and then we can continue the discussion because I have more to go. It's just to give you an insight. So we started with nasal saline, nasal steroids. I thought it was quite. So what I saw in the nose, I thought I will go for clarithromycin. I did that. I tried to convince the patient for allergen specific immunotherapy. She was not too much interested. But actually, I tried to do that. So first, I started with those treatments, clarithromycin, nasal steroids, antihistamine, and the patient did somehow improve. And she said, well, yes, maybe that's fine. However, so I tried to convince her for specific immunotherapy. She didn't want that. She said, no, it's not that. I know my house dust mite allergy, so I couldn't convince her. This is the CT scan. No, this is first the EPOS guidelines. I will not dive too much into because most of you know them, but I think nasal steroids, nasal saline rinses, and then this is this type of maybe non-type 2, but you can't say because he has allergy. So it's certainly an allergic type 2 patient, but it's not a polyp. Maybe long-term antibiotics, but so that's what you do. I think I was part of making this, but I think I never liked it. Now we also have the euphoria, which makes it a little bit more simple. Maybe it's oversimplified, but nasal saline rinses, nasal corticoids, treatment, oral corticoids, maybe endoscopic sinus surgery here, and then you end up with this type 2 and type 1 disease, and you can go for more complex treatments. But I agree that immunotherapy is not in this list, and it should have been.
It's because we're just calling it CRS.
Yes.
I can't tell you how frustrating that is. This
Yeah.
girl, in my opinion,
Now,
she doesn't have CRS, and there you go. She doesn't really have
so the patient comes back to us,
She's got a bit of mucus.
and so this is after treatment with clarithromycin. So after several weeks of treatment, we saw the patient back, and this is the CT scan we do in 2022. So after we did and she says, I still have complaints, I want you to do better. So this is, what do you see?
So just remember, what are the complaints again?
Yeah, she has,
Sneeziness, congestion.
yeah, but also
yes.
headache, postnasal drip.
Postnasal drip,
yeah.
Itchy throat.
This
allergic asthma,
full,
childhood asthma.
yeah.
It's full.
No, yeah.
If anyone thinks this scan is
No, it's not
causing
asthma.
symptoms,
No, it's not asthma.
yeah.
Who would do surgery here? Well, we did actually. We did, and it was mainly because the patient was insisting. We didn't go for immunotherapy. I tried to convince her. Most people know me, and who know me, I'm really much into. So we did.
septal deviation. That's the starting point.
Yeah.
We believe that that has something.
So we did the septal.
Doing a septum and turbinate surgery would do a more benefit than a sinus procedure.
Yeah. So what we did here, we did a sinus procedure and a septoplasty and a little bit of turbinate work. And actually for that patient, she didn't go on immunotherapy after. But I want to ask you, oh no, that's the next patient, I hope. Yeah. What is your postoperative treatment? I know this is a simple patient. It's not a severe nasal polyp patient. So what would you do here as a postoperative treatment? You can vote, and then we will do the discussion. While he's thinking and saying something, we will do you can vote. So this is a simple sinus surgery that many people do, not too much complicated. What do you do after that sinus surgery, immediately postoperative? What are you? So
Because immediately she goes into a honeymoon phase where she thinks she's cured.
Yeah.
And then a year later, all the symptoms come back fully. And then
and then she's ready for immunotherapy, maybe.
Then she's
And I say, you know, I was right, but then she will imagine, she will be recognizing that I was right from the start.
She says she was compliant with nasal steroids in the lead up to the surgery. It just goes, and it was true,
Yeah.
it just goes to show that she actually needed immunotherapy because nasal steroids were not going to suppress her condition. So
Yeah.
it really is a huge problem. This is like repeated all over the world, believe this
Yeah.
dilemma. And ineffective surgery, not
But-
addressing the underlying problem.
I'm happy so I bring cases to have discussions, so if other people have questions on that so I think,
Yes. And
So-
I bet you the sinus cavity looks perfect when she comes back complaining of symptoms. That's
so nasal saline, nasal ointments, nasal steroids, we quite often use certainly the combination of nasal saline and the steroids inside the nasal saline, so that we can really rinse with the corticoids inside. Systemic steroids, I would not do that, but some people do that. Amoxiclavinide, I would not do that. In the old days, we did that, but it's not necessary. Clarithromycin and this. Doxycycline, we have data, I will come later on that in chronic sinusitis, it's not really working. Antihistamines, of course, it's an allergy, and allergen-specific immunotherapy, if after the honeymoon phase she comes back, I think we can tell her then what's there. Are there any comments? Because we will then move to the next case. At this stage, she's happy, and she didn't choose for allergen-specific immunotherapy, but it's only 1 year ago, so it might be that she comes back for...
And you have to be honest here. The only reason surgeons get away with that, doing septum, turbinate, mini-fess in the setting of someone with allergy, is when they meet the patient in whom the allergy is already going out the door as part of its natural history.
But she's only 22 years old.
No, so that's why you're in trouble.
We will see.
She'll be back.
I told her in beforehand that it was immunotherapy, but I have the experience that some of these patients, when you open this osteometal complex area, and they feel they have more air, and of course you did the septoplasty, that you did something. But that's what happened. I will come on the next case because I have several. This is actually a more clear-cut case. It's a woman, 42 years old, a little bit similar, headache, postnasal drip, nasal obstruction, dyspnea, nightly cough. If you look in the nose, you see this nasal congestion, very much congestion. It really looks like polyps. You think maybe this is polyps. Polypoid middle turbinate secretions, House's mite allergy again. As you can see, the lung function, so this is an asthma patient. So here, this is an asthma patient. So here, this is what we call a central compartment allergic disease. Here you see something. What is your treatment here? Should you see it, or can we vote? Central compartment allergic disease.
What are the other symptoms she's getting? She's just congested now.
Congestion, short of breath, nasal.
Does she have a lot of other reactive symptoms? Itchiness, sneeziness, watery?
Yeah, so
hyperreactivity?
yeah,
Is that still
hyperreactivity she has also. So when she's in cold, in an air conditioning, or when she has perfume, she also reacts.
No treatment at this moment.
Yeah, she has had nasal steroids, but probably she doesn't take that very well. So what would you suggest here? What is the treatment? What is your treatment plan? And now it's open, so you can write down what you would do in this kind of patient. Would you go for surgery? Would you go for immunotherapy? Would you go for instructing her better way how to use the nasal steroids? What would you do?
Okay, yes, so that would be really clear. So as opposed to the 22-year-old who's highly reactive, bouncing around with allergic phenomenon, a 42-year-old, same process, by the way. We should make it very clear that you've presented two patients who are likely to be just an IG-mediated inhalant allergy, right? So the first woman had a very exuberant allergic rhinitis and was very reactive. She needs immunotherapy with or without some sort of septum turbinate surgery, in my opinion. I don't think she needed much in the way of sinus surgery. This woman, though, she's now 2 decades older than the asked patient, and in my experience, in most people who are 40 and 50 with central compartment atopic disease are at the end of their allergic life for most of them, and she's got all this tissue remodeling with or without allergy immunotherapy to burn out any residual allergy. I would not be giving this patient a whole lot of pharmacotherapy and nasal sprays. She's got this polypoid thickening, a tissue remodeling response that's taken years to form. It's not going to magically disappear either with pharmacotherapy or allergy immunotherapy. So she's someone who's much more suitable to have an operation.
Yeah.
That would be my approach to that.
Are there other questions or opinion on this? So I see here some surgery, immunotherapy plus minus surgery. You want to comment more?
No, sorry.
No. So I think here the dilemma is there is always a difference what we want and what the patient wants, but it's true that, to my opinion, probably the combination is something which will bring us to a better solution. So I tell to the patient, well, this is not a nasal polyposis, it's an allergic disease. You can do immunotherapy, you can do surgery, but with surgery you will open up, you will not treat the allergy. So I will talk to them through that. So most of the time I try to convince them to do immunotherapy. This lady, and I said, maybe we'll do surgery. So I let the choice quite often to my patient rather than to myself, but I explain very well. What would you do? Would you try to drive her more to surgery, or would you say the combination would be the best thing? Yeah?
And 100%, I tell the patient what I think is the best way to manage them, and I let them then make the choice.
And what would you suggest her?
So I would say to this lady, let's do it. I said, these are all allergy changes. I said, you potentially maybe need to burn that allergy out, but it's created all this thickening in your nose, which we can remove surgically.
Yeah.
But unless you're prepared to engage allergy treatment, it may all come back. And if it looks like it's starting again post-surgery, you need to engage allergy immunotherapy.
So the patient choice was she didn't want to have surgery, she wanted immunotherapy. So we did immunotherapy for more than a year now. She is better. She says, yes, I need less my nasal spray. I said, yeah, you still have to use your nasal corticoid. But she feels fine. She doesn't ask for sinus surgery. I didn't do a repeated CT scan because that was not the question. So I didn't check whether it was gone. When I look in the nose, maybe because also better compliance of the nasal corticoids, it looks better. So I don't have this massive swollen middle turbinate anymore, and she feels better. So at this stage, 1 year later, that's what we did.
Do you think it's the steroid or the immunotherapy that's made her less?
I'm very much convinced that by explaining how to use the steroid and that it's safe to use a nasal steroid, that might be even, I think it's both, it's additional.
It's a bit funny down there. It stops smoking, healthy food, and what? And exercise?
Anti-reflux. I do understand that in some patients when you have a cough and this sore throat, but she's not smoking. Okay, so let's move on to another patient. It's similar type of patients. Woman, 34 years old, she's an artist, she has a house mite allergy since childhood. However, she was diagnosed in another hospital, nasal polyps, nasal obstruction, anosmia, postnasal drip, hyperresponsive to alcohol. She had surgeries in 2007, 2008. In the meanwhile, she developed asthma, and that was also diagnosed. She was on a treatment, and she came to us around 2010, 2011, and she says, my surgeon tells me to have another sinus surgery, but I don't want that anymore. It's horrible. I want to have that. So this is another patient coming in, but now with nasal polyps, with asthma. And again, you are in front of her. She doesn't want surgery. What would you do? Remember, we are 2011. But you can think also today, I see some biologicals, and that's maybe what you would do today. But
Was the pheno really 10?
The pheno was really 10, yes. It's a real patient, I know her. So nasal saline, nasal steroids, she did systemic steroids, doxycycline, only one person. Antihistamine allergen specific immunotherapy. There is no evidence in nasal polyps, although she has house mite allergy. And biologicals might indeed at that time have been the preferential thing. We couldn't include her in a study, which we often try to do. So I think we agree that if you have a patient that had 2 surgeries, has asthma, that then you would go for something. This patient is particularly important because the lung physicians were not too much interested. They say, well, she came once, it's a young person, she's fine, everything is fine, very good lung function, so she shouldn't come back. Again, this is the treatment guidelines. Now we are in type 2 disease, nasal polyps, some atopy, so we can choose for all the treatments, and I think we've done that. What happened here, and that's interesting, it is an eye-opener for my lung physicians, is that if you have a nasal polyp patients, you always have to be careful, because that's allergic rhinitis patients don't exacerbate per se, but nasal polyp patients, suddenly it can go wrong. And this is what happened. This lady was hospitalized for quite a long time with severe asthma exacerbations, and you see she had blood eosinophils really high, IgE really high, IgE to aspergillus. You see here eosinophils were high, and then of course were treated with systemic steroids. We checked a lot of things, and so your patient really had an asthma attack, high dose of oral corticoids, and then tapered down, and a high dose of ICS-LABA. So this lady was young, and she couldn't continue her life at that stage. So what is your treatment here? How would you advance now? Of course, you will, I know what you will say, but we have to have a plan, and maybe what treatment would you give already? We have heard the Klaus talks. Well, what is the way you would proceed here? Knowing that, and then I have to say that the patient still has polyps, bilateral, and actually they are quite large, but she doesn't.
Was she using her inhalers when she got her asthma event?
That's always hard to tell, but she says she was doing that.
Look up the prescription.
No, we can't do that. In Belgium, there is no way to do that. We can't look in the pharmaceutical file of the patient.
Yeah, because if she's really actively managing herself with maximal topical therapy, and she still gets a flare and she's got a nose like that, the biologic is what's going to be the next step.
Of course. So I think here you say dupilumab with a question mark. I like the question mark. I see mepolizumab. Some people noted there was eosinophils very high. The IgE was also very high, too high to start on an anti-IgE. So here the question is really, what will you and the lung physician decide in this patient? But that is, so today I might choose for mepolizumab, maybe dupilumab if the eosinophils are not too high in normal state, because we measured the eosinophils in exacerbation time. So we should look when we taper down the oral corticoids whether you can still give dupilumab, and then I would actually go then for dupilumab if my lung physicians say that. Now it's 2016 and we don't have dupilumab, we don't have mepolizumab yet. So we convinced her to do a sinus surgery. At that time that was the best thing I could do. I did the sinus surgery. Remarkably, and that's something I wanted to show, is that the IgE was dropping from 3,000 to 182, making her eligible at that stage to give Xolair, which was at that stage the only biological for asthma that we could give. So we put her on an anti-IgE, and actually since then she did fine. Now 22, or I saw her even this summer. So since she had the sinus surgery and afterwards the Xolair, the patient is perfect both on the lungs and the nose. So this is just a case. There are several approaches, but it's just... She had Charcot-Leyden crystals. So there is data on anti-IgE, but Klaus showed that. I want to show that allergy doesn't matter for anti-IgE because it's an IgE-mediated disease. It's not, so the patient should not be allergic per se. For lung physicians, they say you need allergy. And now I come to my last case, and I think it's an interesting case, so we will start here. It's a man, 54 years old. He's a pharmacist. He has 2013 diagnosed with late onset severe asthma, nasal obstruction, loss of smell. For us, not hard to find out what that is. This is a CT scan. It's not too bad, actually. He had a hospitalization after an intake of an NSAID. He has been diagnosed EGPA, so eosinophilic granulomatosis. So it's hypereosinophilic syndrome for those who do not know that. And it's a chronic sinusitis, and he has asthma. So we decided to here you can't see it, but in another plane there was some spur that was in the way. So we did an endoscopic septoplasty and a sinus surgery. I did it, I have to admit. I did that sinus surgery. And what is your postoperative treatment in this patient?
And he really did have EGPA, so you had extra respiratory eosinophilic involvement of his body somewhere else.
Yeah. Remember, we are not today, so that was a little bit a problem, but you can think as it would be today. So this is again true, again biological, so you are well trained that in this, I think this is the kind of patients that would need biologicals. And of course, it's the choice what biologicals you would go for here. At that stage, we only had anti-IgE and anti-IL-5, but it was the intravenous one at that stage that we had. So let's move on. Postoperatively, what we give to that patient is doxycycline. No one voted for doxycycline, but we give that, 3, but very little people. We have shown, and that's very interesting, in a double-blind placebo-controlled trial with doxycycline, and we looked for the wound healing after that. Should we give a treatment of 8 weeks with doxycycline, and then we looked for wound healing, and we looked also for other cool things in our lab. And that's interesting, if you look for wound healing, those with polyps have a worse wound healing than without that one. The ECRS, eosinophilic chronic sinusitis, based on the JESREC versus non-eosinophilic chronic sinusitis, have a worse wound healing. So the wound healing was a combined score that me and Thibaut and Klaus, we scored by looking into the nose postoperatively. And high and low to moderate IL-5 that we measured, you can also see on that. So eosinophilic disease has more poor outcome in wound healing. Now, if we give doxycycline for 8 weeks, you see that in nasal polyp patients that you have actually an improvement. Also, ECRS patients have improvement in their wound healing. So we were quite impressed by this result. We are trying to publish this. We are finalizing and making still some cool measurements. But we see that we have more. It's not just an antibiotic. It has an anti-inflammatory effect, and that's how this works. So that's why we still believe in doxycycline as a cheap, good drug for postoperative care. But we give this, and after my surgery, the polyps returned quite fast back. And of course, Klaus and Thibaut said, yeah, but maybe you didn't do the reboot, so maybe we can do better. Incomplete surgery. No, I did a full complete surgery, but the polyps returned quite fast. And here I will ask your treatment, but your treatment will be a biological, so we will move on. We started intravenous resizumab because at that time that was available by the lung physician, so the eosinophils dropped dramatically, but the polyps returned, and we did another sinus surgery under the resizumab. So we thought, yes, let's combine surgery with an anti-IL-5. That will be a cool thing. That's what will help. That's the golden bullet. Maybe that's it. But you hear from what I'm telling you that was not working that much. We can give anti-IL-5. Klaus gave already some details. I wanted to give you some last update on that, is that if you give anti-IL-5, it's not the fastest one, but when you stop it, it looks like it doesn't, the effect, it's a slower drug, but when the effect doesn't disappear immediately. And that gives us some option in the future, maybe of tapering in those patients when it's working. but indeed the effect is slower than in the other two drugs. I wanted to highlight something else. Klaus talked about, are eosinophils important in nasal polyps? Probably they are very good markers, but are they important in disease? I'm not so certain, because this is benralizumab, is an anti-IL-5 receptor. The double-blind placebo-controlled trial, actually by Klaus Bachert, showed that it was not so good. And we were surprised. We thought it would be the same as mepolizumab, but it didn't work that well. So there are many ways to think about that. I will come why that could be. We have some hypotheses here. But what is certain here is that it doesn't work very well on nasal polyps, but if you look in the tissue, the eosinophils are gone. It's depleted. So what's the role of the eosinophils? And there is another study with dexpramipexole. It's a drug that depletes eosinophils completely from the tissues. It has no effect on nasal polyps. So is eosinophils important, or are we missing something? Is it just a marker? Now, we don't know. So after 25 years studying Klaus and me, we are not yet certain what the role of the eosinophils are, and that makes our life very interesting. Let's continue with this patient. We switched from reslizumab to mepolizumab because maybe that was better. We did another sinus surgery under mepolizumab because we thought that would work. And, well, it didn't. We did a revision after a revision. Sorry, Klaus and Thibaut and myself, that we had to do all the sinus surgery. But the patient is really horrible. His asthma is bad, the nose is bad. It's not like really polyps. It's this thick, inflamed mucosa, always with secretions there. So another revision surgery in 21. So what's next? Now remember, the patient has really high eosinophils. And with Dupy, there is some comments that maybe with the high eosinophils, you should be very careful that eosinophils don't go high. Is it really so? Because into the tissue, we see that eosinophils go low when you give Dupy.
We're going to scare the audience off in thinking that at a sinus course that sinus surgery doesn't work by discussing such a patient. You've picked a patient that's very complex. Opening the sinuses up and putting them on topical treatment is not really a major part of the EGPA care. And I just think, we just have to be cautious with our audience.
Yeah, but that's why I had 5 cases before.
Yes, I know. But we should make that really clear. I think just to show how you have to have a strategy, surgery is not the solution for diffuse disease.
Yeah, but I think that's the message, that even with very good surgery and even with a biological, that it can be complex. So the give Dupixent.
How much mepolizumab did you apply? How much mepolizumab did you apply? 100 milligrams or higher?
It's 300. It's the long and it's the long dosing that the patient has. Yeah. So indeed, it's true. So this is the history. The patient has sharp-olide crystals. All the surgeries. The patient was put on mepolizumab plus dupilumab. I just want to show you what we did. There was a big discussion, should we do that? The lung physicians were very firm. They said, we won't use dupilumab alone. We are afraid of the high eosinophils. It was not our decision. We wanted dupilumab. We asked for dupilumab. We got dupilumab. And of course, dupilumab works. I didn't want to show all the slides again of the nice trials. But this is an open... this is a real-life observational study from Amsterdam showing the effect on SNOT22, the really nice effect. So they have good effects in real life now, and this is great. This is what happened to our patients. So, this is what we saw always, this thick, reddish mucosa with secretion, and then we give on top Mepo plus dupilumab, and you see that it's getting better, and also the CT scan is better. But more importantly, also the symptoms are really improving. Even the lung function, which was good following the lung physicians, it was even improving. Now, I wanted to show this case because I wanted to come to some pathophysiological insights. But you have a question, Jessica. point what we really want to do.
My bad.
Yeah, no. We didn't do that. But we are trying to suggest it to our lung physician and to the patient, but the patient is a little bit... Yeah, the patient is also scared because the patient is really good now. So the patient tells, this is the first time in
Well, I'm sure the lung physician has said, oh, eosinophilic crisis is terrible, and we don't want that to happen.
So interestingly, the eosinophils dropped immediately when we give the anti-IL-5, and of course now when we give Dupi on top, it stays low. So we were not having this increase in eosinophils because of course we give anti-IL-5, but we did the cool thing. We collected nasal secretion to do proteomics, and what we see is that the eosinophilic markers even improved by adding dupilumab. But more importantly, also your neutrophilic inflammation, and that's, to my opinion, one of the key things we are forgetting. We have to think about neutrophils as well. It's not only eosinophils. They are going hand in hand, those guys. So if you kick out the eosinophil, your neutrophil might come in. So you see that you have a normalization on eosinophilic and neutrophilic markers. Even the IgE in the polyp is going down in the nasal secretion of this patient. And this is just what I want to end with, because I think it's interesting, is if you treat with no biologic, you see eosinophils, not so much neutrophils, you can have a mixture of that, it's a little bit more complex than that. If you treat with mepolizumab, the eosinophils go away, but neutrophils tend to come up. If you treat with benralizumab, it's the same, I will show you. Omalizumab also. The dupilumab seems to dampen down both. And I think here what you see in benralizumab is interesting, is that you deplete eosinophils completely, but neutrophils seem somehow to take over. Maybe that's good. You don't want a neutropenic patient that has no defense. On the other side, we see that here, the more you deplete your eosinophils, the more the neutrophil come back. So that might be one reason why completely depletion of eosinophils is not good. That might be the reason why mepolizumab works better than benralizumab and then dexpramipexole. We don't know. It's all hypothesis. I just want to show you that with working with this patient and then doing sequencing and look for the genes expression, that we can try to understand now how these things are coming. It's just to highlight and to show which direction we are going. I want to finalize with some remarks. If you have a primary nasal polyp patient, only primary nasal polyps, it's clear that dupilumab is the best. Best on the nasal polyp score, very good in symptoms. The smell is going well. Omalizumab, what do we do with that treatment? It's a cheaper treatment. In Belgium, it's only 120 euro for an injection, so it's clearly less expensive. So for countries that don't have the money, I think it's a good option. It's safe. You can give it in pregnant women. It's not the most potent one, but it seems to do something. In certain patients, you really can control it. Mepolizumab is not a very fast treatment. Also on the nasal polyps, it doesn't seem to do that much. But on the snot, you have quite some effect. So you look in the nose, the polyps are still there, but the patient says, oh, I'm fine, you don't need to do a sinus surgery anymore. So mepolizumab is an interesting one. Benralizumab doesn't work, and they didn't ask for approval. So if you think about what to give to your patient, it's not, if you have a primary nasal polyp patient, it's easy, it's Dupi. If you have a patient with asthma, you have to sit together with your lung physician. So we need united airways guidelines to think about. So it's good to have these options. And Klaus unfortunately had to retire because of the Belgian regulations, but we are happy now to have Anne-Sophie Ekels instead of him, and she's also around. Thank you very much.